Dr. Khan, thanks for the kind introduction. I got to tell you, like Rich, this is very special to me. This is my first meeting I've been at in over a year. And so it's phenomenally impressive to see all of you out, and it really warms my heart to have this opportunity. Dr. Khan, thanks so much for the kind introduction and the invitation as well. I have also learned that I should never sign up to follow Rich in terms of a presentation, because that was amazing. I learned a ton. And so my goal, I have a lot of varied interests. I'm a general clinical cardiologist, but my goal is to update you about atrial fibrillation. My only disclosure related to that is I'm not an electrophysiologist, but I think I'm going to try and help share something old and something new, to borrow from Rich in this regard. So I have no disclosures. And these are the learning objectives. I'm not going to read through this, but I want to be able to cover what are the principal goals of dealing with patients who have atrial fibrillation. And so I'm going to do my best to be able to walk you through the totality of information today. It's a lot to cover. I'm going to do my best to leave sufficient time for Q&A as well. So this may be basic for a lot of you, but when we talk about atrial fibrillation, it's important to understand what it is. It's the most common sustained arrhythmia, not only in the United States, but also worldwide. And fundamentally, it causes two sets of problems. It actually causes way more than that, but most of us spend our time focused on symptom alleviation and reducing the risk of thrombotic consequences, namely stroke or systemic embolism. I will point you to the fact that we use the term broadly in terms of atrial fibrillation, but there are some classifications that are listed at the bottom. So if people come back and start talking about paroxysmal versus persistent versus long-term persistent versus chronic or permanent, there are actually definitions behind those. And this primarily relates to how you, or in shared decision-making, you want to be able to engage with your patients about the direction of their care overall. So who gets atrial fibrillation? This is probably well known to all of you. This is actually data from Northern California, from the Kaiser Permanente Northern California group, just showing the relationship between prevalence of atrial fibrillation as one ages. And this is true, as you can see, for men and women alike. And as one increases in age, these are by 5-year increments, not by 10-year. There's a stepwise increase and an appreciable increase as people get into their 7th and 8th decades of life. So much so that we're beginning to ask the question, who doesn't have atrial fibrillation as they become an octogenarian? Now, that's a little bit tongue-in-cheek. The overwhelming majority do not, but it's a highly prevalent condition. And yet we will also see people who have atrial fibrillation at much younger ages. I saw somebody last week diagnosed with AFib at age 33. Those are unusual circumstances, but this is the typical pattern. So why do we care about atrial fibrillation? Well, we care for a lot of different reasons, but this is the striking data in terms of projections. And these are 4 different modeling analyses. You can see that 2 of the analyses in red and green reflect that from Olmsted County. For those of you unfamiliar, that's where Rochester, Minnesota, that's where Mayo Clinic is. They do a lot of population, sort of community-based cohort analyses looking at the projections. And as you can see here, some more conservative, some more liberal. We're going to have a huge growth. Why? Because as we are aging and the numbers of baby boomers turning age 65 are precipitously increasing, we're going to see much more atrial fibrillation in years to come. There are a number of risk factors that I'm going to talk about for atrial fibrillation. Those too are rising in prevalence. So it's really a combination of an aging population enriched with risk factors that predispose to atrial fibrillation. And this is just the condition, let alone the risks related to it. This is obviously a pictorial display of even more why do we care about it. And this is to illustrate the fact, and most of you may have actually heard of Virchow's triad. Virchow was a pathologist who recognized the relationship between essentially 3 different components: stasis, a hypercoagulable state, and vessel injury, that those essentially predisposed to, most commonly we think of as a DVT, deep vein thrombosis, or a pulmonary embolism. But actually that collection or that predisposition exists in people with atrial fibrillation that can accelerate the production of a clot, most commonly within the left atrial appendage and outpouching off the left atrium. About 90% of strokes are the result of a clot that originates in that area. And that's illustrated in this right lower corner on a transesophageal echocardiogram. But this is a major thing that we're trying to prevent, and it's always the most disheartening thing when you see someone whose first manifestation of a stroke or systemic embolism, their first manifestation of AFib is coming in with a new stroke. So what causes it, or at least is associated with it, and this is a really busy slide, maybe purposely busy, to say that there are a lot of chronic, common conditions that we see that are at least associated with atrial fibrillation, and mechanistically, and we don't have time to go into each one of these, but there are a number of reasons why several of these may actually be a link and actually causally related to the development of atrial fibrillation as well. I put this in just to talk about basics of an initial evaluation. Again, I'm not going to read through this, but talk through some of the basics about what you should be asking about with a history. Recognize that large percentages of individuals either may be asymptomatic with atrial fibrillation and or may have less typical symptoms, or I would say not discrete symptoms that you can say, aha. And we all gravitate to palpitations. Do you ever feel like your heart's beating irregularly, abnormally? Do you feel like it's racing? But most commonly, you'll talk to people and they said, I feel fatigued, I just don't feel well, or they may have lightheadedness. And as we know, there are a lot of other conditions that can predispose to lightheadedness and fatigue that are unrelated to atrial fibrillation. Obviously, looking at precipitating factors, we hearken back, or at least I do, to holiday heart, or people that might binge on alcohol over the holidays or on a weekend that can actually trigger atrial fibrillation. There may be some selected examples like that. The physical exam can be helpful primarily to figure out, are there other cardiac abnormalities that may have actually driven a predisposition to AFib. The electrocardiogram is obviously of principal importance to establish the diagnosis or at least confirm it. An echocardiogram, and then I've listed some additional cardiac and laboratory tests that are very appropriate. One, just to call out, obviously being an assessment of thyroid function, as hyperthyroid state is one of the few conditions in which we can potentially prevent or make atrial fibrillation go away if it's directly connected to their hyperthyroid state. So these are cartoons just to illustrate what are the goals of what we're trying to do with people with atrial fibrillation. And again, I'm not an electrophysiologist, so I don't pretend to be one. But for me, when I see patients, this is really principally about stroke. I didn't have room to say /systemic embolism, but it could be a stroke or a clot that embolizes elsewhere. And then on the right-hand side, it's symptom control. And we're going to talk about both rate and rhythm control for this population. So let's dive in with stroke reduction, and it's been an area of interest of mine, but I will say in addition to this, there are large unmet needs in this regard, and that there are millions of people with atrial fibrillation who, at least worldwide, are suboptimally treated, along with the United States. I'll show you some data about this. We do have effective therapies. They're not without potential risks that can help to mitigate the risk of stroke. But it's really amongst the most disheartening when someone had a recognized diagnosis of atrial fibrillation, was not on optimal antithrombotic therapy, and then experiences a stroke or systemic embolism. And as many of you may know, Rich and I spent our times trying to treat people with heart failure and heart attack. But one of the, I think, most feared complications that people will have if you talk to almost any patient is that they're left with a disabling stroke and having to be cared for by loved ones or others. So I want to start by saying, and there are key takeaways for this, but asymptomatic atrial fibrillation is anything but benign. And this is illustrated here. This is a community-based analysis of prognosis in 1,000 patients with AFib. They had no preceding complications. And this is a look over time. On the left-hand side, you can see the incidence of stroke or TIA. On the right-hand side, this is survival free of death. So you want to have your curve higher up, closer to the 100%. And it looks at people with atrial fibrillation with typical symptoms, those with less typical symptoms in the asymptomatic population. And there's nothing unique about an asymptomatic or atypical presentation that should make you have a higher likelihood of having a TIA or stroke or a higher likelihood of death. Rather, these people may not be recognized as much, or there's an impression by people, this person doesn't have classic symptoms, or they're asymptomatic, I don't have to worry about mitigating the risk of stroke because they have no symptoms. And this data at least bears out that's not the case. An interesting thing that many of us in the cardiovascular community struggle with is, does the burden of atrial fibrillation make a difference? And I'm going to start by saying and acknowledging we don't fully know the answer to that. The answer is a larger burden is associated with increased risk. What is that threshold burden of atrial fibrillation that pushes you over the line to be susceptible to stroke or systemic embolism. And the data that we have comes from a unique population. It's those people that actually have implantable devices. They have a pacemaker put in for a completely unrelated reason, but we've got a machine that's continuously looking at their heart rhythm, and if they go into atrial fibrillation, did they or did they not? And if they did, for how long? So this is a pooled analysis, about 10,000 patients, determine the risk of TIA or stroke based on various durations of AFib on cardiac implantable electronic devices. I'll blow up the bottom portion here. But in this analysis, simply having 5 minutes or more of atrial fibrillation was associated with a statistically increased risk of TIA or stroke. So I can't get into all of the studies that have been done. I'm not saying that this is the definitive answer, and Ty said it's 5 minutes, that's the threshold. There is some debate about this, but needless to say, even brief durations of atrial fibrillation, and there's a very elegant paper that was put out in the New England Journal several years ago that actually looked at 6 minutes of any supraventricular arrhythmia was associated with an increased risk of stroke or systemic embolism. A vast majority of those people had atrial fibrillation, but the bottom line is that even brief durations may predispose people. And so I have patients who come to me who say, I know when I'm in atrial fibrillation, or at least I think I do. I worry about how often they have it while they're sleeping or they don't recognize they go into it, because for every symptomatic patient, we know that there are a number of asymptomatic episodes they may experience, but simply trying to mitigate the risk of stroke or systemic embolism based on timing is fraught with a lot of error. This is another study, and this also comes from the Kaiser Permanente group. This was the KP Rhythm study, retrospective study, 1,965 patients, determining the risk of thromboembolism based on durations of AFib. What you can see here is a lot of people who have AFib have rather brief durations. Their burden of atrial fibrillation is modest. So most people are just not having atrial fibrillation all the time. They're having shorter durations overall. And what they did was they looked at tertiles based upon the percent of time in the analysis of being in atrial fibrillation. All 3 tertiles were associated with a significantly increased risk of thromboembolism. It is true from a point estimate standpoint, those that had a larger percentage of time had a higher likelihood, but there's wide confidence intervals. And the bottom line is even brief durations or brief burdens of atrial fibrillation make you susceptible. So I'm going to get up on my soapbox. I guess I'm sort of up on a box, but I'll get up on an either bigger box here to say everybody warrants an assessment of their thromboembolic risk. And so the CHADS-VASc score is not the only risk stratification score, but it's the most widely utilized score worldwide. And you should get in the habit, in every single patient with atrial fibrillation, of assessing their risk of stroke or systemic embolism. The contributing factors are on the left-hand side. There's a stepwise increase in their annualized risk. This is just showing stroke alone, of a stroke alone based upon their score. Higher the score, the higher your risk of thromboembolism. And I want to be very clear, because this is a population health analysis, but the discussion you're having is with a patient. So if, for example, their score is 4, they're approaching a 5% annualized risk, that doesn't mean that they're going to have a stroke this year if they don't go on an anticoagulant, as an example. But each year that goes on, they are taking a 5% chance. And I'm not a gambler, but I wouldn't be willing to gamble on those odds. But that's the calculus that we have to do for all of our patients. This is an elegant study. It's a rather simple study done by Ben Steinberg when he was at Duke, highlighting the fact that we as clinicians, and I mean that broadly, physicians, nurse practitioners, physician assistants, we and others don't do a very good job at assessing stroke or systemic embolism risk. We'll sit there and look out and say, that person looks high risk, that person looks low risk. And this is borne out by here. This was 10,000 patients in the Orbit AF registry looking at a more formal assessment. In this case, it was looking at the CHADS-2 score, the predecessor of the CHADS-VASc score, comparing to that to a physician, and now I'm picking on our physicians, myself included, the physician-assigned score, without using an objective measure. And what you can see is we tend to skew towards perceiving people's stroke or systemic embolism risk as being lower than it really is. So if we assign it without any formal assessment tool to do that, we will tend to skew people's stroke or systemic embolism risk as being lower than it really is. I'm not showing you the slide. We also tend to estimate people's bleeding risk to be higher than it really is overall. So how do we go about reducing the risk of stroke or systemic embolism? These are pooled data. These are meta-analyses. Now, Rich lives in a world of heart failure where we have smallish trials in the cardiovascular space, some of the larger trials in lipid space, 10, 20,000 people. If you go back to the original studies that have been done for aspirin versus placebo and stroke, you could see the number of events and the number of patient year study were at 3,000 patient years. These were small studies, but it's what we have. And I don't want to actually poo-poo aspirin in this regard. It's associated with an approximate 20 to 25% relative risk reduction compared to placebo in reducing the risk, in this case, of stroke in this patient population. On the right-hand side is the most commonly utilized vitamin K antagonist, warfarin, and you can see the relative risk reduction is about 60%. And we've all had patients, regardless of your background, on a vitamin K antagonist, almost certainly also for atrial fibrillation. They've had limitations, but there's no question anticoagulation, the use of an oral anticoagulant, supersedes the value afforded by antiplatelet therapy. If some is good, more must be better. Now, we live by that adage in other parts of our life, but that does not apply to antithrombotic therapy. So this is a cohort study of 82,000 plus individuals in Denmark. I'm always very, I'm jealous of what goes on in Denmark and Sweden. There are pluses and minuses to different healthcare systems, but they have the ability, because of their system, to effectively track a lot of different data on people, and this is the kind of analyses that can be generated. So they looked at 82,000 plus individuals in Denmark, discharged, this is not a randomized study, but discharged after hospitalization for AFib, so that's what they came in with, on either warfarin, aspirin, or clopidogrel, either alone or in combination. Now, of no surprise to you, this is where more is not better. On your left, non-fatal and fatal bleeding, as you stack antithrombotic agents, you increase the risk of bleeding. But on the right-hand side, when you look at non-fatal and fatal ischemic stroke, you do not generate incremental benefit from stacking antithrombotic agents. So all you are doing by adding more blood thinners, for lack of a better word, is engendering a higher risk of bleeding. As many of you know, over time, we have had the benefit of having additional therapies developed. I think one of the real advances was the introduction of Doax, direct oral anticoagulants. They will go by names Noax, novel oral anticoagulants. You may have heard Tosoax, target-specific oral anticoagulants. There are a lot of different vernaculars, but these are agents that in a head-to-head comparison, in order to be approved, were compared to warfarin, vitamin K antagonist, in at-risk patient populations to mitigate the risk of stroke or systemic embolism. Where is their bread buttered, if you will? They are associated with an approximate 50%. This is a meta-analysis that was published by Christian Ruff now about 7 years ago, but an approximate 50% reduction in hemorrhagic stroke, 50% reduction in intracranial hemorrhage, and a statistically significant reduction in all-cause mortality compared to warfarin. We'll get back into how our guidelines have embraced these overall. I will say that as a class, in totality, they are associated with a very small increased risk of GI bleeding. There is some heterogeneity amongst the different agents, however. So what do our guidelines tell us? In 2019, the American College of Cardiology, the American Heart Association, the Heart Rhythm Society came up with their updated guidelines, and this is what they pretty much say. If we start at the bottom, which I think is easiest, if you're a man with a CHA2DS2-VASc score of 2 or greater, or a woman with a CHA2DS2-VASc score of 3 or greater, and remember, being a woman is one of the factors that gets you an extra point in the CHA2DS2-VASc score. This is attempting to normalize based on sex, that the recommendation, class 1A for warfarin, class 1B for a Doax. But at the very bottom, the direct oral anticoagulants are preferred in all eligible patients over a vitamin K antagonist over warfarin because of the data that I just shared with you overall. And so the populations that I would just call out that there are exceptions to what I just said, people who have moderate or greater degrees of mitral stenosis, or people who have had a mechanical prosthetic valve. We have data clearly that Doax should not be used in that latter group. One trial showing increased risk of thromboembolism and increased risk of bleeding. In those with a CHA2DS2-VASc score of 1, as a man, 2, or as a woman, oral anticoagulant therapy receives a lower indication, but I think we're seeing more accrued data that even in this lesser but still at risk patient population, there is benefit. And again, the guidelines do endorse it. It's just a lower level of that recommendation. And then lastly, if you're a man with a CHA2DS2-VASc score of 0 or your only score is 1 because you are a woman, it is reasonable to omit anticoagulant therapy, but that does get a Class 2A Level B recommendation. Admittedly, this is a little bit dated, and we do have some contemporary data that's due out, hopefully in a publication in the next few months. But needless to say, what happened after the introduction of these drugs? And it's a little bit busy, so I don't want to go through all of the detail. Warfarin is illustrated in this red color. Green is dabigatran. Rivaroxaban is in the bluish color. Apixaban is in purple. And not shown on here is the fourth DOAC, edoxaban, primarily because of low uptick in utilization. But largely, the first thing I want to call out is of people eligible for oral anticoagulant therapy prior to the period of around 2011, look to the left far portion. Roughly 50%, 50% of people eligible for any oral anticoagulant were receiving none. So roughly half the people with AFib who already the guidelines before this said they should be on an oral anticoagulant weren't receiving one at all. All we had at that time pretty much was a vitamin K antagonist. Over time, since the introduction of these, at least for a period of many years, we really robbed Peter to pay Paul. We saw a decrement the use of vitamin K antagonists with an increase in the use of Doax. Now, we've seen Doax use rise over time. Cost was a barrier to their adoption. But the data today would suggest as many as 30 to 35% of people with a CHA2DS2-VASc score of 2 or greater still are not receiving oral anticoagulant therapy. Obviously, you're going to say, Ty, you're not talking about safety, you're giving a blood thinner. I get really worried about these types of things, and these are the feared complications. And I want to be clear, GI bleeding and other types of bleeds are still important. On the left-hand side, you'll see a pictorial display on a CT scan of a subdural hematoma, and on the right-hand side, you'll see an intracerebral hemorrhage. Now, I do want to be clear, for the most part, people can bleed spontaneously, but in most circumstances, under most circumstances, these types of events usually follow a traumatic event. Somebody's up cleaning their gutters, they fall off a ladder, they're on an anticoagulant, they strike their head, and they're in with a subdural hematoma. And I can assure you, as you all well know, somebody falling off a ladder on aspirin, a vitamin K antagonist, a DOAC, is going to be more likely to bleed because of being on a blood thinner than they otherwise would have. So I'm going to try and thread the needle of weighing the risks and benefits of oral anticoagulant therapy. This is a retrospective study of nearly 14,000 patients. Admittedly, almost half were women. About 40% were greater than or equal to 75 years of age, with non-valvular atrial fibrillation treated in a large integrated health system. Again, where this is the Kaiser Permanente Northern California group who's done a great job over time. I'm going to have you look over on the right-hand side when you look at this, and if you look, this is comparing warfarin to not taking warfarin. The use of warfarin was associated with a 41% reduction in the risk of ischemic stroke, and that was associated with a 94% relative increased risk of intracranial hemorrhage. Now, I do want to, it's important when we talk about relative risk is what's the frequency, the absolute frequency of events. So there was, roughly speaking, about a 0.7, close to 0.8 absolute reduction in the rates of ischemic stroke at the expense of a 0.2 increase in an intracranial hemorrhage. So there is no such thing as a free lunch with any antithrombotic therapy that we use. Rich talked about this with aspirin. It's true for oral anticoagulants. The goal is to try and maximize efficacy, minimize bleeding overall, and I would argue that the data illustrated here, if the Doax were applied, that rate of intracranial hemorrhage would be 50% lower than what we're observing here overall. I often hear people say, my patient is 87 years of age, they're 91 years of age. I'm not an ageist, I don't think anybody in this room is, but you begin to worry more about what if they fall? What about the risk of a subdural hematoma according to age? On the left-hand side, probably of no surprise to you, this is looking at CHA2DS2 score, not CHA2DS2-VASc. Your benefit goes up from using warfarin compared to not using warfarin as your CHA2DS2 score goes up. And age is a driver of calculating your CHA2DS2 or your CHA2DS2-VASc score. If you look at, this is net clinical benefit. This is looking at the totality of ischemic event reduction, marrying in with it bleeding events, and arriving at, when you take efficacy and safety and blend them together, what is the overall effect? they actually multiplied, and you might say this is unfair, they actually weighted intracranial hemorrhage 50% more than an ischemic stroke, making the argument it's a worse outcome than a stroke. We could debate what the right weighting should be. Needless to say, on the left-hand side, as your CHADS-2 score goes up, it's incrementally more, the net clinical benefit is that much greater. But on the right-hand side, age, you see a greater and greater and greater benefit from people who are older, in spite of the fact that that population potentially may be at higher risk of bleeding overall. So I want to strongly discourage withholding oral anticoagulant simply because of age, because that's the population as one ages that's most likely to drive the benefit because their risk of stroke or systemic embolism goes up. And I can't help myself, this is one of my favorite studies to quote. It's a Markov analysis, it's a modeling analysis, but I think it illustrates things because I hear a lot from colleagues who will say, persons at increased risk of falling. They may never have even fallen, or they've fallen twice, and I don't minimize the impact from the standpoint of a broken hip or a musculoskeletal injury overall. But this was a Markov analysis looking at the strategy amongst people greater than or equal to 65 for falling with no other contraindications. And what they did is they looked at the literature and they said in this population greater than or equal to 65, the average adult in this population falls 1.8 times per year. Now, some are going to be bigger falls, some are going to be lesser falls. The risk of intracranial hemorrhage in their analysis must be 535-fold greater for the risk of warfarin to outweigh the benefits. Persons taking warfarin must fall about 300 times in 1 year to not be considered optimal therapy. Now, I know that you might say this is a little bit of funny math, etc., but my point simply is you're trying to prevent a potentially fatal or disabling stroke. Yes, there are bleeding risks. Yes, there are consequences if someone falls, but simply falling. I mean, my first question is if you fall, is there an assist device that you could be using? Are there other things? What's the etiology of the fall? Rather than simply saying, I'm withholding an anticoagulant because someone fell once, twice, 5 times. In this case, it would have to be 300. You may ask the question, Ty, the guidelines have come out with not only a risk stratification score for predicting risk of stroke or systemic embolism, but also bleeding. And I'm showing up here just a couple of them. There are more than this. Has bled on the left, Atria on the right. These are a number of predictors. And one thing you will observe very quickly is several of the identifiable variables in these are the same ones that increase the risk of stroke. So yes, as you get older, your risk of bleeding goes up and your risk of stroke goes up overall as well. The important thing, and this is well stated in the guidelines, but unfortunately not highlighted in an effective way, the value of these risk scoring systems are primarily to identify reversible causes to address bleeding. If somebody's taking a lot of nonsteroidal anti-inflammatory drugs, and that's precipitating their bleeding, and now you're putting them on an oral anticoagulant like warfarin, you may exacerbate bleeding. So the goal of a has bled score is to identify, are there things that my patient has in inventory that I could be doing to prevent them from bleeding while they're on an oral anticoagulant? It's not used to determine who shouldn't be on oral anticoagulant therapy. To sort of round out this section, I will say that there are people who have prohibitive bleeding risk. I have people, I'm up in Portland, Oregon, there are people who are sawmill operators. They've cut themselves once or twice and nearly bled to death when they weren't on an oral anticoagulant, so there may be occupational reasons. There are people who have had intracranial hemorrhage in spite of not falling. They have a vascular malformation that can't be operated on, they're susceptible to bleeding, and there are other conditions well beyond that. My point in saying, because, as I illustrated earlier, that the left atrial appendage, this outpouching of the left atrium, is the source for 90% of the clots that embolize, that go up to the brain and cause a stroke, or to your foot and cause systemic embolism, is the concept that you could actually exclude or obliterate, prevent the left atrial appendage from communicating with the left atrium. So clots can develop in there, but if you prevent those from actually transiting out of the left atrial appendage into the left atrium, down the left ventricle, and then out of the heart, and then going loose, can you actually do this? And we've known for years that you could exclude the left atrial appendage in the operating room with cardiac surgery, but in this case, these are a number of devices, some approved, actually really one approved, several under investigation, looking as a vehicle to try and percutaneously exclude the left atrial appendage. from the left atrium. And this is data from the PREVAIL trial. This is using the only FDA-approved device, the Watchman device, looking at 407 patients, non-valvular AFib, CHADS 2 score greater than or equal to 2. These studies were done before we sort of moved to CHADS VASC, looking at the risk, in this case, a composite of stroke, systemic embolism, or cardiovascular unexplained death, comparing them to the population that are on warfarin versus those that are initially on warfarin for an abbreviated period of time, allowing the device to re-endothelialize, and then they stop their oral anticoagulant. And you can see these curves are nearly superimposed. And I did my best to try and make my own, essentially, pictorial display. On the left-hand side, you can see the ischemic endpoints. On the right-hand side, you can see the bleeding or safety endpoints overall. I do create a new category called Procedural Complications, and these rates have gone down over time, but this is trying to give you a perspective of the three of the four FDA-approved Doax, warfarin in gray, and the only left atrial appendage occlusion or closure device that's out there to give you a sense of how effective they are from a stroke, systemic embolism, and a bleeding standpoint overall. I will just say the caveats here, these are different populations, so I'm basing this data on the data that came from the trials that led to the approval of these devices or drugs, but cross-trial comparisons comparing two different trials when the drugs haven't been compared head-to-head can be a little perilous. So let me change directions and focus in now on symptom control. Obviously, there are two fundamental approaches, and they're not mutually exclusive. So it's rate control and rhythm control. In many cases, we're using rate control agents like beta blockers in people who also may pursue a rhythm control strategy. Again, I'm not going to read through all of this for you, but these are a couple of the rationales for why rate control matters. In many cases, not all, the symptoms may be due to higher heart rate. I feel palpitations, I feel fatigued, I feel lightheaded when my heart rate's going 160, 170 beats per minute. And just to qualify this is, thank God we have an AV node, because in the atria, the term fibrillation is appropriate because the atria are beating, in that case, at roughly 400, 450 times a minute. A fraction of those beats get down to the lower chambers of the heart, to the ventricle. So when we see a heart rate of 133, that's not reflective of what's going on in the atria. It's the slowing conduction, either pharmacologically by drugs that we give or someone's intrinsic AV node. It's often why younger individuals with AFib will have higher heart rates because they have more intact conduction system. As we age and our conduction system begins to wane, our ability to conduct those beats goes down. It's also the rationale why an AV node ablation, literally separating the atria and ventricular conduction, can slow, no heartbeats get down, and then you're pacemaker dependent. So what's the right heart rate for people with a rhythm control strategy? This is an older study, now over 10 years old, 614 patients, permanent AFib, randomized to a lenient rate control strategy, less than 110 beats per minute at rest. I want to be clear, that's not with exertion, but at rest, versus trying to get the heart rate less than 80 or less than 110 with moderate exercise. And the bottom line here was there was no difference over a 3-year period of this approach. Now, this was with a goal of 110. If someone's heart rate's 140 or 150, that's well outside the range of what was explored here. But there are a lot of people who will come to me and they'll say, my heart rate's 102, I'm asymptomatic. There isn't a fundamental rationale or need necessarily to get their heart rate lower, absent having heart failure with reduced ejection fraction or other reasons. One of these reasons is illustrated on this slide here, though. This is a really well done, and it's actually a rather small study, 29 patients undergoing AV node ablation for drug refractory AFib. So these are people who, in spite of every drug, just could not control their heart rates, could not control their symptoms, and they had to go in with the help of an electrophysiologist, essentially deliver energy or cryoablation therapy to the AV node, render it inactive, no impulses get down, and you're now pacemaker dependent. But what's very interesting is if you look at the people on the left-hand side whose baseline ejection fraction was 50% or greater, they had no change in their ejection fraction. Look what happened on the right-hand side, though. People who had reduced ejection fraction, these people saw an appreciable improvement in their heart squeezing function, their left ventricular systolic function, as a result of having this procedure done. That will be re-illustrated in just a short bit. So the bottom line for rate control is you're predominantly doing this for symptom management. There are some patients who have heart failure with reduced ejection fraction, which to Rich's point can be effective by controlling their heart rate and getting it down in improving their LV systolic function. But essentially, the goal is to keep their heart rate at a reasonable level. And the RACE-2 trial, that lenient strategy, 110 at rest is a reasonable heart rate, at least as of what we know today. Rationale for a rhythm control strategy, a lot of these points are listed up here. Of note, this can be done essentially 2 different ways, and the second way in 2 different sites overall. You can use antiarrhythmic drug therapy, or you can ablate them, and the ablation can take place in the EP laboratory or can take place in the operating room. Now, if we go back quite a ways, this was published in 2002, so almost 20 years. This is the RACE trial. Some of the earliest studies that people will quote took individuals, tended to be older in age, and those individuals had relatively modest symptoms. These were not the most symptomatic of the AFib patients, and asked the question, in this population, does subjecting those people to rate control, bringing their heart rate down into a desired range, how does that compare to a rhythm control strategy that would use antiarrhythmic drugs that could help maintain you in a normal rhythm, prevent recurrences of atrial fibrillation? But as many people know, these always, or sometimes I should say, have double-edged sword in the sense that some of these drugs, while being antiarrhythmic, can have a potential pro-rhythmic effect, etc. In this 522 patient trial published in New England Journal of Medicine, persistent AFib, prior cardioversion, randomized to these 2 strategies, there was no difference whatsoever in terms of the rates of this composite endpoint that's listed here. And as you can see here, rate control was actually a little bit better as overall. Different study, the AFFIRM trial, same concept, much larger study, almost 10-fold larger, 4,000 patients, AFib, randomized to rate versus rhythm control strategy, 3.5 years, no difference. When you look at mortality, mortality was lower in the rate control strategy. Not statistically significant, but I would just say numerically lower. And this is what took the wind out of the sail from a rhythm control strategy from antiarrhythmic drug therapy. You look at these trials and you say, well, why would I use a rhythm control strategy? And I think it's what led to a downturn in the use of antiarrhythmic drug therapy. And then 2020 occurred. Now, 2020 obviously will live in infamy because of the pandemic and everything else, but this is one of those interesting trials that I think turns the world on its head when you think of rhythm control. I don't know that even the investigators thought about it in this way. So I'm going to walk you through this. This was the East AFNet 4 trial, and this was just presented last year, published in New England Journal of Medicine. Almost 2,800 patients. These were people within 1 year of atrial fibrillation. And they had an additional cardiovascular risk factors, and they were randomized to either a rate versus a rhythm control strategy. And I just want to show that AF ablation is this pale blue color at the bottom, and the other colors, minus the gray, which is no antiarrhythmic drug therapy, are all different antiarrhythmic agents. Propafenone, flecainide, amiodarone, dronedarone. These are a hodgepodge of antiarrhythmic drugs. And you can see here initial and then 2-year what they were getting. On the right-hand side, you could see the composite of cardiovascular death, stroke, or hospitalization for heart failure and acute coronary syndrome. And the early rhythm control strategy was associated with a 21% relative risk reduction in this composite endpoint. Now, an adage you will hear in cardiovascular medicine is AFib begets AFib. The more AFib someone has, the more AFib you will have. It can result in abnormal structural remodeling of the atria. They can grow in size. The left atrium perhaps is the best barometer of cardiovascular health. Large size, dysfunction, not a good thing overall, and that correlates well with data from hypertension, from heart failure, etc. So a question that's asked is, in somebody who has new onset AFib within a year, can you change the trajectory of their outcomes by trying to prevent them from having more AFib? And we haven't set this loose, this just got published last year, to know how this is going to impact practice. But I'm already beginning to hear about colleagues who say, you know what, the person's relatively asymptomatic, they're not that bothered by it. Should we be more aggressive at pursuing a rhythm control strategy? And lastly, I just want to round out by saying the rationale for catheter ablation, the rates of ablation for atrial fibrillation in the EP lab has risen significantly over time. I was fortunate to train at a place where they were one of the first places doing it in the United States. And we didn't know when we were first starting. People would come in for an ablation. They'd come in for what they would call a touch-up. They would come back again overall. And I want to be very clear, anybody who says you can cure atrial fibrillation with catheter ablation, frankly, from my perspective, is totally misspeaking. You cannot cure atrial fibrillation. You can reduce the burden. You can reduce the symptom limitation by reducing the burden overall. And the guidelines affirm over and over again, you do nothing to reduce the risk of stroke or systemic embolism. So anybody who's had a catheter ablation for AFib should still remain on the same anticoagulant they were prior to going to the EP lab overall. Nonetheless, based on what I just shared with you with the East AFNet 4 trial data and additional data that I'm going to share in a moment, is there a rationale for doing this more? I'm not an electrophysiologist, but only to say that most of the data suggests that most AFib originates from the pulmonary veins, the muscular sleeves that sit around the back of the left atrium that essentially cover the most commonly four pulmonary veins. And so by electrically, anatomically isolating those areas, you can actually prevent those wavelets of AFib originating from the pulmonary veins from spreading out. I don't want to go through all of this, just to say there's a sophisticated area for people way smarter than me who can electrically and anatomically map the impulses, and then these little dots represent where they're either delivering radiofrequency energy or cold energy, cryoablation, to try and isolate that. 2 key trials I just want to leave you with. This is one where your taxpayer dollars went to work. This was the Cabana trial. This was funded, published in 2019, and this was going to be the pivotal trial. 2,200 patients, AFib, randomized to catheter ablation, pulmonary vein isolation, like we described, or antiarrhythmic drug therapy for, in this case, more than 4 years. And unfortunately, they missed for their primary efficacy endpoint. On the left-hand side, you can see that composite endpoint. Interestingly, a secondary endpoint, not the primary endpoint, mortality or cardiovascular hospitalization, one of the key endpoints we look at in heart failure, was statistically reduced, almost a 20% relative risk reduction. But this trial stands out for me, and it builds off things that Rich was just sharing. This was published in 2018, much smaller trial, 363 people. This is the Castle AF trial. And this took people with paroxysmal or persistent AFib, unresponsive, intolerant, or unwilling to consider antiarrhythmic drug therapy, and they had heart failure with reduced ejection fraction, EF less than or equal to 35%, and class 2 or greater symptoms, randomized to catheter ablation or medical therapy for over 3 years. You can see on the left-hand side, survival free of hospitalization from ablation in blue compared to medical therapy in red. And this is all-cause mortality on the right-hand side, associated with a nearly 50% reduction in all-cause mortality by ablating people with heart failure with reduced ejection fraction. So in summary, these are my takeaways. AFib is a common condition with a prevalence that is expected to increase significantly over the next 10 years. Some even estimate that the projections I shared earlier may be underestimates. It's associated with a significantly increased risk of stroke, whether the patient is symptomatic with classic symptoms, symptomatic with atypical symptoms, or asymptomatic. A patient's risk of stroke or systemic embolism should be assessed in all patients, regardless of the treatment approach, because as Ben Steinberg shared with us earlier, we as clinicians do a rather poor job of assigning risk both for stroke and bleeding. Preference is now given to the direct oral anticoagulants over a vitamin K antagonist like warfarin for a vast majority of patients who warrant oral anticoagulant therapy, exceptions being moderate or greater degrees of mitral stenosis or mechanical prosthetic heart valves. Left atrial appendage occlusion or closure now represents an alternative to people who cannot be on oral anticoagulant therapy but otherwise warrant it. And then the choice of a rate versus a rhythm control strategy depends in part on how symptomatic you are, when it was diagnosed, new to us in the last year, and underlying comorbidities like heart failure. With that, I enormously appreciate the opportunity to speak to you today, and I'm happy to answer questions. Thank you.